The HIV pandemic continues to be a major global public health problem. It has been 35 years since it began, and HIV/AIDS has infected 78 million people and claimed 35 million lives. Africa remains one of the most affected regions in the world. Out of the 38 million people living with HIV/AIDS worldwide in 2019, 70%, that is 25.7 million people, are in sub-Saharan Africa. There's still no cure for HIV infection, but medicines called antiretroviral treatments that can control the virus and stop people from passing it on to others are available and widely accessible, even though not to everybody who needs them. From the time the HIV pandemic started, it took more than a decade between 1996 and 2006 before Africa could access antiretrovirals. And during that time, Africa lost 12 million lives and African economies lost an entire decade. And since then, billions of dollars have been invested in the AIDS response, and the investment has paid off. Between 2000 and 2018, antiretroviral therapy has reduced new HIV infections by 37% and HIV-related deaths by 45%, saving 13.6 million lives. And yet, despite all this progress, the global AIDS pandemic continues to have an African face. And that face is the face of an African woman. It is the face of a young African girl between 15 and 19 years old and a young African woman between 20 and 24 years old. Women between 15 and 49 years make up more than half. That's 57% of all Africans who are HIV positive. And 75% of those are girls and young women between 15 and 24 years old. It is a catastrophic outrage that, with all the billions that have been invested in the HIV response, Africa on its own continues to be responsible for 66% of all new infections. Why? How? Welcome to another episode of Let's Talk About Health in Africa. My next guest is the phenomenal world-class South African clinical epidemiologist, Professor Quarraisha Abdool Karim. She is a UNAIDS Special Ambassador for Adolescents and HIV and the Associate Director, Scientific Director for the Centre for AIDS Research at CAPRISA in South Africa. Professor Abdool Karim pioneered the understanding of the evolution of HIV epidemiology in young women. She is a strong advocate for the rights of people who are living with HIV and affected by HIV, and a champion for young women's participation in science, technology, engineering, and mathematics. She has received numerous excellence awards for her work, including South Africa's highest honor, the Order of Mapungubwe. Professor Abdool Karim, welcome to Let's Talk About Health in Africa.
Good morning, Lenias, and thank you for having me on here.
It's a pleasure, Prof. So let's take a look back, from the early days when you started looking at the factors that make African women, especially young African women, so vulnerable to HIV. There's an article in the Financial Times in which you said that young women's potential is ended before it begins. Can you just tell us about your work and how it led you to make this devastating conclusion?
Yeah, so that's a good place to start this journey that spans over 3 decades. So in 1988, I had the opportunity to study at Columbia University to do public health, which during apartheid South Africa was viewed as subversive, and we had no schools of public health. And I finished high school in 1976 during the time of the student uprising. My first degree was largely caught up in anti-activist protests, and a lot of the 80s, even as I continued to work as a medical biochemist, I was doing a parallel a sort of life where I was working in communities that were very disadvantaged. And so in doing that, I got to understand better how apartheid policies was influencing and disadvantaging the majority of the population in South Africa on the basis of race. And so this opportunity to study public health actually brought together for me this passion I have for science and social justice. On returning to South Africa in 1989, I reflected on my year in the US, where we just recently discovered that HIV causes AIDS. There were many symposia, and just looking at the epidemic as it was unfolding in New York City, and then interacting with people from other parts of Africa, describing something similar unfolding there. The first question I started to ask myself on my return is, so why don't we know about HIV in Southern Africa, and particularly in South Africa and the province I live in KwaZulu-Natal? And I used the opportunity of an active malaria control program to undertake one of the first population-based studies. So my first question was, what is the magnitude of HIV in KwaZulu-Natal, the province I live in? And in doing that survey that included about 5,000-6,000 people, I found that HIV was rare. It was less than 1% in 1990. But what was striking when I did the age and sex disaggregated analysis, so first I did the sex disaggregated analysis, and I found that women had 4 times more infection. When I did the age and sex disaggregated analysis, I found that young women 15 to 19 had 6 times more infection compared to their male peers. And that when you move to the next age band, 20 to 24, you're seeing this increase to the point where about 12% of women at that stage were already infected with HIV. And then you see this 5 to 7 year difference in terms of when we start to see HIV in young men compared to the women. So immediately, when I saw this, the question as a nice inquiring scientist is why? And so I engaged in a whole lot of socio-epidemiological studies amongst women in urban, rural, peri-urban populations, and also sex workers. And, at that stage, sex work was illegal. I worked with mothers of teenage kids because, of the restrictions, working directly with adolescents. But eventually I did get to schools and health facilities. And the thing that was coming through very strongly, because by then I'd done 2 other surveys within a 24-month period, and found this trend was continuing. And then I'm seeing this, here's the magnitude of the problem. So of course, I was seeing the rapidity of the spread of HIV, was seeing this consistent pattern of young women. And the 2019 UNAIDS Global State of the Pandemic data, or 2020 report based on the 2019 data, shows that 25% of the infections globally are in young women 15 to 24 years. So I didn't start off saying, I'm going to study young women. The data took me there. And then when I did confirmatory and repeat trials looking at temporal trends. There was consistency in that. And then I was hearing from the women themselves, whether they were mothers or in sex work or adolescents, that they understand their risk. But everything we had available depended on male cooperation. So if your partner, say you're 20 years old, your partner is 25 or 26 or 27, you likely would have had a child and dropped out of school. So you get caught up in endless and vicious cycles of poverty and dependency. So you need a man in your life, and a man for accommodation, a man just to like survive. And now this man, you're trying to ask, tell him he may have other partners, as we've learned. It's his behavior putting you at risk, not your behavior. So that's when the conversation with this diverse group of women I was interacting with started to shift to, well, can't you give us something to enable us to protect ourselves? So I just wanted to go back to your original question about luck. So I hope this background helps you understand it. So what happens is when young women get infected with HIV, up to about 2005, it was inevitable death. So, many young women, before even reaching the age of 21, were dying from AIDS. They were dying from complications from pregnancies. It's children having children and the complexities of that in terms of their health and also the health of their children. So what we're seeing is this intergenerational impacts, because we know when mothers die, the life course for the child is very different from if a mother finishes high school and then, has the cognitive ability has matured, what she decides and how she decides, and her life trajectory is so different. So what I was talking about that I had gleaned from the data and confirmed with the socio-epidemiological studies was that, in terms of development, we look at survival of infants. And so if infants die within the first year of life, and the larger the number, we say that's like really, this country is doing very badly. And over the past 30 years or so, we've done a great job in terms of equal numbers of girl children and boy children surviving age 1, age 5, age 10. And then what we're seeing is as young girls enter this phase of secondary, as young boys do, secondary sexual development, we're seeing a divergence. And that divergence was being manifested, and the indicators for it was HIV and pregnancy and STIs to some extent. And that's what I was talking about in the financial, that for young women in many parts of Africa, their potential was being wiped away during this period, and all the gains we'd made while they were children, and now as they're entering adulthood, was being undermined, and that we needed to pay attention to this because 65% of the population in Africa is under the age of 35. That means our demographic dividend is the youth. And if half of that youth are being lost by age, before the age of 20, it's a cause of serious concern. So that's like a little bit of a long story, but the sort of long answer to your short question.
No, absolutely. I mean, it really sort of explains, the data was speaking for itself. It took you there. And it's quite interesting for me that it was always so clear from the beginning that this is where some of the problems are greatest, losing young women in the prime of their lives, just beginning, their life as an adult. But since then, we've made a lot of progress, right? We've made progress, putting people on treatment, bringing treatments to the people who need them, even though we are still not reaching everybody. What I cannot get my head around, given how clear it was that young women were disproportionately affected right from the beginning, your early studies looking at that and what the data was showing, I can't get my head around why rates of infection amongst young women are still this bad, after we have pumped billions of dollars of investment in this pandemic. We have more people more aware of their status, 85%, and of those 79% are receiving treatment or thereabouts, and they are managing to suppress their viral loads, which means that the opportunities for transmitting the virus are so much lower. So it's a tremendous amount or size of resources that we have invested in prevention. Why are things not getting better in terms of how we control the epidemic amongst young women?
So you're right that in the investments that have been made by countries through the Global Fund for AIDS, TB, and Malaria, and also with the US Presidential Emergency Program for AIDS Relief, we have made enormous progress, including especially in Africa, where we're home to about 70% of the global burden of infection. And as like South Africa has less than 1% of the global population, but 1 in 5 infections are in South Africa. And so when we think about these investments, where have we made such a huge progress? The first is in reducing transmission from infected mothers to their infants. And I remember in the province of KwaZulu-Natal, where I come from on the east coast of South Africa, the transmission rates in the 90s used to be 30 to 40%. And it is now less than 2%. Wow. We had until 2002, 2003, in Africa, we didn't have access, unless you could afford it, to antiretroviral treatment. But these solidarity programs enabled us to introduce ARVs and to see the benefits. And we can see how life expectancy has improved.
Yes.
But we also need to take into account that between 1995, say, and 2005, in many parts of Africa, we lost adults in our communities by the hundreds of thousands. You may not recall this, you look very young, but you may, just have been born around then. But if you ask your parents and your grandparents, and I remember, times where I would travel to Uganda and see between the airport and getting to the city, just lines and lines of people making coffins. Of course, these days you don't see that because, that's the transformation that treatment has brought. Yes. But what it's important to recognize is there are about 38 million people living with HIV, and the majority of those remain in Africa. And that, if we look at how many people we've reached with treatment in the global context, and of course reflected in Africa, we've reached about 60% of the population of infected individuals. Right. But what we're also learning is that, the benefits of treatment, for example, if you're virally suppressed, you can prevent onward transmission. But here, what we've seen both with PMTCT and with antiretroviral treatment provision, the focus has been on health facilities. Right. And who uses health facilities are primarily women. Yes. So women are being tested and their children are being tested. In fact, in several countries, 8 times more women have been initiated on treatment compared to men. So the opportunities for men to test, be initiated, etc. There's a toggle with workplace programs and testing, but it goes back to some additional work we've done more recently, where at CAPRISA, for example, we try and look at the issue of young women in terms of understanding transmission dynamics, understanding, here there are behavioral issues, but we've also learned that there are biological factors driving this. And then, simultaneously, we've been trying to intervene in terms of primary prevention. So globally, while we've initiated something like 28 million people on antiretroviral treatment, and we're seeing the individual survival benefits, when we look at prevention, after the UN high-level meeting in 2016, that member states adopted to say we'll end AIDS as a public health threat in 2030. We are doing well, and so UNAIDS took that and did the fast track strategy. And you're right, in terms of PMDCD 90-90-90, overall we've been doing pretty well. But where the challenge has been is in primary prevention. The target for 2020 was 500,000 infections globally. What did we have in 2019? It was 1.7 million. And remember, 2020, we saw COVID-19 come in, SARS-CoV-2 virus, causative organism of the COVID-19 pandemic. And, in our responses, particularly, and if you think about Africa, where you have multiple pandemics and epidemics, you've got Ebola, you've got TB, you've got HIV, you've got malaria, and now you have COVID. And in COVID, I mean, the pictures we were seeing, the visuals of what was going on in Italy, in the UK, in New York, I think many of our governments did the right thing to institute national lockdowns, restrict gatherings, shut down schools, and prevent international travel and so on. And in the first wave, we were able to slow down and cope with the cases that we saw. In the second wave, and now some countries are even going through a third wave, it's been less of an issue. But one of the casualties of that immediate response was our response to HIV and other essential services. And there was the two parts to it. One was the issue of access to services. The other was where users were voting with their feet. And, there was this fear, if I go to a health facility for X or Y, I'm going to get COVID. And so there was, this supply-demand issue where could you access the service for anything other than COVID? And two is like, even when you could, after a few months, like you didn't want to because of other fears and concerns that you had. And I think the latter half of 2020 started to see a bit of right sizing, but then, there's always the issue of budgets and adequate attention. And I have to say, I think the HIV, that our investments in Africa, in the Ebola response, in the establishment of Africa CDC, in the numbers of infectious diseases personnel, both providers and researchers we had, I think it gave Africa an advantage in terms of rapidly pivoting to respond to COVID-19. But now in 2021, as we have COVID vaccines and we know a lot more, we cannot afford for HIV to be another unfinished epidemic and pandemic. And I say epidemic because of its concentration in Africa as a continent, and that it behooves all of us to continue to make sure, one, we sustain the gains and the successes that we've discussed earlier in terms of treatment, in terms of PMTCT, but also to focus on preventing, primary prevention. And that's a challenge because with primary prevention, you're really coming to the hub of the issues of vulnerability within our society. And across the board, there are different issues driving local epidemics, driving national epidemics. But the thing that's really uniform is that the populations that are bearing the brunt, they may be 10 to 20% of the population, but that's where you start like if you take young people and young women, the ability to access services, and in the midst of moral and judgmental approaches and attitudes by young people. We take substance use, which is growing across Africa, and the criminalization of that as opposed to managing that addiction and in different ways. Same-sex relationships, criminalization of those, criminalization of sex. So the population and groups that we need to be reaching, we're not reaching them. Right. And we're not going to reach them because they don't come to the health services. So when you look at health service data, you'll think, wow, you're doing a brilliant job. But then when you look at the big picture, you see, who are we leaving behind? And we're leaving behind the most vulnerable in our communities, and the most marginalized and the most discriminated against. And the variety of the discrimination and marginalization varies across Africa, but wherever it is, you will see this continued spread. Like if we take young women, for example, what did we learn? With the more state-of-the-art technologies like sequencing of the virus in recently infected individuals, in 2016, we were able to show the schematic about 3 groups that are important for transmission dynamics. It's men 25 to 40 years, it's women under 25 years, and women over 25 years. So where are these young women getting infected from? They are exclusively getting infected from men 25 to 40. Now, when you think about this cohort of children that we have under 10, going to 10 to 14, going to 15 to 19, it's like an open cohort coming in. And as they enter this 15 to 9, under 25-year age group, they are having relationships with these older men. And in fact, the mean age for 15 to 19-year-olds to get infected is men 11 or more years older than them. If you take 20 to 24, it's about 8 or more years. Now, when you look at women over 25, they are having relationship with men who are their peers, about a 1-year age difference. Now, if we only had sex between women over 25 and men over 25, we would have seen the end of the epidemic. But the fact that these men, about 40% of them, are simultaneously having relationships with younger women, you have the cycle of transmission. So these young women getting infected, the high numbers getting to 25, and then you have this peer transmission taking place. So if you want to break the cycle of transmission, one of the things we've done is focus on women-initiated technologies for young women. This is 8 years, 15 to 24. If we can keep this group uninfected, we can alter the trajectory. And that's where the women-initiated technologies come in, and we have daily oral Truvada, tenofovir plus emtricitabine, and now we're seeing, monthly rings, we're seeing 2 monthly injectables, and there's even work to look at 6 monthly injectables, annual implants, and that space is really growing rapidly. But the thing is that the men, they don't know their HIV status. They recently infected. In fact, in the same population-based survey that we did that we've been doing in one of the highest burden districts in KwaZulu-Natal, we found like about 40% of the men had a viral load over 50,000. So it means, the risk is changing. So if you look, even though it's rare up to age 25, When men get to 25, between 25 to 30, in that 5-year interval, they go from less than 5% HIV to 40%. That means in that group, they're getting infected, the incidence rate is high, the viral load is high, the antibody tests we're using will not detect that. And so you need, better high generation tests to be able to detect infection that early. So they don't even know they're infected. If they go and have a test and be testing with antibodies, you won't even pick that up. In the meantime, they're at their most transmissible stage. And so this is one of the factors. Then for young women, we also see biology plays a role, and our work analyzing the CAPRISA 04 cohort shows that something called genital inflammation or vaginal dysbiosis enhances their risk, one, of acquiring HIV, and two, is also reduces the potency of tenofovir gel. We're trying to understand is that now, so you got PrEP as a potential protective agent, but is the potency of PrEP reduced in the presence of this genital inflammation, which is very common? We've seen, for example, we're trying to understand all the factors contributing to it. But what we do know is that if you have dysbiosis, the lactobacilli crispatus dominance, which is very protective in a healthy genital tract, it goes away. And so you have these other, what was commensals, suddenly becoming pathogens. And so the sort of low pH, the hydrogen peroxide, and more importantly, it mobilizes your immune cells that are the ones that HIV likes. So we see even low virulent strains of HIV are able to establish infection. And so if you didn't have inflammation, you wouldn't get infected with those strains of HIV. But because you got this high concentration of CD4 activated cells at the genital mucosa where exposure is taking place, the probability of getting infected is so much higher. And so, so this is like some of the things. And then the what is, even as they described all the expanding options of women-initiated and more ARV-based prophylaxis, we still, access is a challenge. So few countries have been able to do this. So when we think about in the grander scheme of things, yes, we have made enormous strides scientifically, but it's the challenge is in implementation, one, but two is actually understanding and meeting the needs of those that are most vulnerable in our societies. And that's where the fundamental issue of gender power disparities that underpin this. So in all this, we have to address those because, I use this as an example when I'm addressing male policymakers and decision makers in Africa is, if this was your daughter, would you support your 15-year-old daughter having a relationship with a 25-year-old or a 30-year-old? And so all of these young women, you should think about them as your daughter. And are we doing the right things to nurture and protect a group of people? And, there's the flip side, which is that young women are also being more assertive. And I'd say great for that, because we can't sit there as victims. And sometimes in the assertiveness, certain behaviors actually increase vulnerability. So we have to think about one's safety and how do we make that safe with the technologies. They're just the first step. But fundamentally, to right our society, to realize the demographic dividend we have in young people and all young people, we need to think bigger in terms of gender power disparities and how at different levels in society, because This doesn't occur in isolation. It's about couples, it's about men taking responsibility, it's about women also making decisions not on today, but thinking about tomorrow. And these issues about how do we ensure comprehensive sexuality education. And I mean, the thing we haven't spoken about is gender-based violence. I mean, we've seen it as a silent and not so silent parallel shadow pandemic. I mean, it was across the globe, but especially in Africa, we were seeing the worst. And when we think about it, women play such an important role, both in the formal economy and informal. They are the majority of the frontline healthcare workers. They in the front line in the manufacturing and retail space. So, when some of us could afford to take our computers out and work on Zoom and work remotely, the majority didn't have that luxury. They don't have the luxury of data. They don't have the luxury of remote working. They have to don their work gear and get to work. Early on, when PPEs were limited, who was getting the brunt of that? It's women again. And so, when there were safety nets being put out by our governments, women are not part of the formal economy by and large. So they didn't get the benefits of that. So they do the home industry, they do the informal economy. They're the one, selling the vegetables and whatever at the markets, on the pavements and the street sides. And women-headed households are common in Africa. And you have to say, these households don't appear. They were men there, and women-headed households with children. So this is about male responsibility as much as it is about societal and government appreciation of the role and contributions of women. And that if we don't pay attention to this, we are going to miss the opportunity that our youth and this demographic advantage we have that young people bring yet again.
It sounds so complex and yet also maybe quite simple in that, there are simple things that could be done, including getting men more involved in prevention strategies. If men are not getting tested, obviously, and their risk increases as they get older, as you're explaining, above 25 years old, they are transmitting a lot more with intergenerational sex. But it seems to me that the early prevention strategies really somehow, it seems to me that they've really missed the mark in terms of, including all of the people who should be involved, getting men more involved, perhaps education about, preventing violence, I don't know, using protection, because you hear a lot, in the earlier days, right, that women should just abstain, be faithful. So you see women who perhaps do not necessarily engage in high risk behaviors actually having a very high risk of infection. Then there is the attitudes of society towards women, the participation of men in this, and the men who are making decisions and coming up with policies or interventions that are really specifically speaking to the challenges that are affecting young women in society. Just explain a little bit more what we should be doing better, or what we should have done differently in terms of primary prevention and getting men to be a part of this, as part of the solution, because you cannot simply target women and expect the problem to go away. Clearly, that's not working.
Yeah. So if we're going to change this war on women, and this war begins very early, as I said, at this secondary sexual development, we cannot target men when they're 25 and older. We have to focus on men younger. And so, you have this is where vertical programming has its disadvantage. So in HIV, you want to we have to do many things. Some of them give you returns quickly, some of them don't. And the investments in young men are not going to give you HIV returns anytime soon. Because if you invest in young men 15 to 24 years, it's only when they're over 25 that you're going to see the HIV impact and that impact on women. So when you do that, though, when you do that investment, it's starting to get to the root cause, because the toxic masculinities that you see and the irresponsible behaviors, etc., are not going to change when you're adults. You have to start that earlier. And so it's both with young men and young women. When they're young, if we can start to inculcate a certain value system around self-respect and around health and what that means, around what does it mean to be a woman, what does it mean to be a man, then I think we are on the right trajectory. Because when you have power, power is not a zero-sum game. And I think it's often interpreted like that if women have more power, men are going to become powerless. But in fact, when men and women have power, what is possible is actually synergistic. So all of society benefits when you're able to do that. And earlier on, I said, in the development literature, we knew this way back in the 70s and 80s. You see this, year after year, time and time again. When you invest in women, the trajectories are much better for the entire family, for entire communities. And what's happening here is that, the gender-based violence, which is not just about what happens in intimate relationships, but it's the random acts of violence, the rape against women, and so on. It's the kind of objectification and monetization of women that we have to change, that our cultures have brought us historically, have respected women. We've had matriarchal societies. Women were respected. So somewhere along the way, we've lost that value of respect for women. And as mothers, we have to inculcate it in our sons. As as community leaders, whether it's faith-based or other leadership, how do we instill it? Because it's fundamentally about social cohesion and almost calibrating our communities and societies to one where we have to remind ourselves of what is important in our lives. And sometimes I think with capitalism and the greed that's there and the consumerism, we lose important values that we have about hard work, about how we respect each other, and that the latest hairstyle and clothes is not what this is about, and who's on your arm or whose arm you are on. That as women and as young women, there are immense opportunities. And I think we have to start expanding that opportunities to young men as well. Because while we're uplifting young women through a whole lot of interventions, because we're not taking the young boys with us, there's a kind of alienation that's coming in, and you see that with the increase in substance use, in the abuse. It's all of the stuff that's starting to unravel, and to write those after years and decades of oppression is not easy. But we can make it as complex as it can, or we can start to take small steps. As I told you at the beginning, this is Freedom Day in South Africa. So I have to quote Madiba. He, many wonderful, inspirational thoughts that he's left us with. But the one which is, it's always impossible until it's done. And you climb one hill and you find there are many more. But, the thing is, we have to move forward. And we start crawling before we start walking, before we start running. And it's the small steps that start to add up. And I think when I look at COVID-19 and I see the leadership from the African Union, I see the Africa CDC and the work that John Kengasong and his team, I think we have an opportunity to start that journey. And we can do that if we collectively believe in it and we collectively commit to it, and then we can start to see the change. I think that young people in Africa are impatient, and rightly so. There are many talented people like yourself taking the initiative, showing leadership, and that's where the hope is.
It's always impossible until it is done. And that used to be the argument that was used for at the beginning when people were trying to argue for bringing antiretroviral therapy to Africa, that it was economically not possible or sustainable. The numbers were too large. And yet today, look at us today, we have so many people on treatment. So these are not impossible things if there is political commitment and political will to get them done. And this idea about the way we are raising our sons, I think it starts in the home, right? Because I'm a mother of a daughter, and you see amongst us, our peers, the kind of behaviors we reinforce in, that my peers who are raising sons reinforce, and what we're teaching girls. It's a world of difference, right? What we are rewarding as good behavior. So I think those things have to start within the home, then going to society, and then everything about the way we raise our sons, we raise boys in society, education, right? Starting with, how ministries of education works with ministries of health in making sure that those kids, both boys and girls, are inculcated with the right kind of values that goes back to who we are, right? A society that respect women. I say this to my husband a lot, that, it really surprises me, that where we're coming from. I'm from Zimbabwe, and one of our biggest national heroes is a woman. And yet when you see everything that happens now, it doesn't seem to speak to that value that we've had, that we respect women, we celebrate women as heroes. So I think that's really quite important. So from what you say, Prof, I mean, what are the prospects that African countries will reach the 2030 targets? We have so much, like you said in your FT article, there's so much to do. We are so far away. I mean, what are the chances we are going to reach these milestones with everything that needs to be done that is not happening?
So I think that you're right. When you look at it, it sounds like one of these insurmountable challenges that face us. But I think that in HIV, there have been important lessons that we've learned that we can build on with Ebola as well. So I think it's not just governments and what governments do, but I think it's also the role of civil society.
Yes.
And civil societies are not powerless. And I think that we underestimate the power we have as civil society. And we saw that with treatment, because it was civil society protests and movements in Africa and also globally that enabled us to move from treatment that was life-saving but unaffordable to something that's affordable. And today, across the globe, if you have AIDS, you are treated the same way. So it's achieved equity. Now, with COVID-19, initially there was this issue of, well, this is a global problem, and global solidarity. But then when the vaccine started to emerge, suddenly we saw this nationalism coming in, and me too first, and my community. And with epidemics, it doesn't matter where you are, the virus doesn't respect it. The virus will go wherever there's opportunity. So this is a shortcoming in leadership, where I think this better balance of an active civil society is so important. And a couple months ago in November, there was the UNAIDS PCB meeting. We have a new executive director, and the response to HIV has evolved over time. And I think we have the science. We have, we can have more science, we can have a vaccine, we can have a cure, but we do have the tools to actually reach those 2030 targets. What we lack is imagination and the will to do it. And so Winnie's taken a more inequality lens to the problem, and showing, if you take the numbers and you unbundle the numbers by region or by country, you can see how it tracks inequality. So whether in the US, it's like Black MSM being excluded, and how the burden of infection is so much higher. We saw that with COVID, how the cases track where there are racial and other inequities in place. And so we learned the same lessons in COVID as we learned with HIV. It's the poor, it's the marginalized, it's the discriminated against. And I think the time has come where we cannot afford to, no, they're not part of us. They're not. In Botswana, for example, they reached 90, but the incidence rate was over 3%. Why? They didn't count sex workers, they didn't count migrants, they didn't count same-sex relationships. So you can't count and exclude your parts of your population. That's it. And, we have to look at it locally. We have to respond appropriately locally, and then it adds up nationally. So I'm like a big believer, even my research, I always say, I did this because it was a problem in the communities I live and work in. It's not like somewhere else. Now, the whole thing about women-initiated technologies is an African problem. It's a problem it's a social challenge fundamentally, but that the technologies was an important first step. So we have to look at it as Africa bearing the brunt of the HIV pandemic. We've made good progress. We got to make sure we don't drop the ball and continue. And the prevention challenges, and I think it's not rocket science what those challenges are. And there's no magic bullet, there's no silver bullet. These are complex challenges, and where one size is not fit all. So with PMTCT and treatment, one size fits all. If you're positive and you go on treatment, if you positive mother to prevent, it's one size fits all. With prevention and primary prevention, it's not one size fits all. So you have to have a much granular understanding, and that granular understanding comes from local engagement. We know this. If you ask the local CSOs, the CBOs, the NGOs, they'll tell you what needs to be done. They also know how to reach the populations much better than governments can, much better than our health services can. And so we got to not just have these important groups at the table, part of decision making, but we have to put enough investments to enable the delivery that needs to happen through the groups that know how to do this. Because, Einstein said, if you repeat this experiment, you can give it 10,000 times, you're not going to get a different answer. If it's wrong, it's wrong. You're going to see this 10,000 times. So we've got to move away from repeating the same things that's not working. And we have to look at not just, we used to do this ABCs, and ABCs was okay. Now we have to look much more, what is the this epidemic, where our hotspots in the country, where are the most infections, why is it happening, and what combination of interventions we need to put into place to actually change it. And we need to do it to scale. We need to monitor it to see, is it having the impact? If it's not having an impact, stop it. Don't do it. Go back to the drawing board. Measure the thing that you want to measure. Is it preventing infection? If it's not preventing infection, it's not going to prevent infection. Rethink it. So it's not like overthinking. It's really about smarter thinking, smarter interventions, smarter measurements, and it'll get us there. I know it, and I'll give you a brilliant example of it. In this rural community where I work in, and I told you about the cycle of transmission, usual stuff. We believe it's not about just knowledge generation, not your high impact. The high impact publications are good because it tells you it's excellent science, but it's also about communicating with the key stakeholders and the public. And one of the things we did was kept sharing this widely with others. And one of the princes from our royal family decided, I'm going to do something about it. So what did he do? He started this Isibaya Samadota campaign. And I think as a Zimbabwean, there's enough common language. It's Isibaya Samadota roughly translates to men taking responsibility together.
Yes.
And he started to work in community, like personally going into communities and talking to the men. And he targeted men 25 to 35. And so we saw like a 200% increase in testing in men in that group, in these communities. And then he saw, well, they weren't being linked to care because of the hours of the clinics. And he said that he convinced the Ministry of Health to do mobile services for treatment initiation. And then what we saw was, better survival in the men, one, but two, a 41% reduction in HIV in young women under 20. So it shows when you do the right things, you see the right metrics emerging, taking you in the right direction. And so KwaZulu, the province of KwaZulu-Natal, everyone's looked like, what happened? And say, what happened was Isibaya Samadota, that we took the men taking responsibility. And I mean, there's lots more. That's where, I told you like the issues of the recent infections that we MERS and so on. But his father, who's, passed away a few weeks ago, yes. For example, when medical male circumcision data became available from the 3 trials, he said, KZN, highest burden of infection in South Africa. We don't do circumcision in the Zulu community. But what he did was he reminded the Zulu men that it was a practice. And it was during the wars where Shaka put a stop to it because too long for the soldiers. And that was when it stopped. And he said, no, what he also saw was there were these traditional practices by like packs and so on that were causing young men to lose their penises from gangrene and aseptic procedures. So he said, you're going to go to a doctor to have the circumcision, but then we're going to link it with the traditional educational and rite of passage stuff about what does it mean to be a man and be responsible. So to me, there were 2 examples just in KZN where I work, where this partnership with communities, and then, we have other things like Sukumasake, where it's about, like the principle of Ubuntu. Like we are because of others, and when we respect ourselves, we protect ourselves, and us protecting ourselves protects others, and so on. So those are, and that's why I say it's not just governments, it is about everybody seeing it as important and willing to put the time and the effort to make sure we do the right things. And then I think that takes us straight on, maybe even reaching our goals and targets, maybe even before 2030. And it's the right thing. It's for us in Africa, it's not like somebody else's problem, it's our problem. So if we put it, and we can do what we did with COVID-19 and continue HIV responses and fill these gaps and remaining challenges, who's to say where we can go and how far we can fly and how high we can fly?
It seems sometimes you look at these things and you feel like, my goodness, it's such a lost cause. But it seems that if we have community leadership and individual leadership where people are stepping forward and saying, what can I do, right? What do I have the power to do in my community to change this problem? It takes us very far, and I guess nothing is impossible then if we could all take responsibility for what's happening within our communities. That's such a powerful lesson for me. I think, we could all really use a lesson like that.
And the science is an important first step, and the scientific method is like how you think about things as scientists.
Yeah.
So we're about solving problems.
Yes.
So sometimes, and as I said, the science is there, the evidence is there. It's now taking that evidence and applying it. And so when we take people and we empower people to have agency, yes, not to feel helpless. And so when we take it in like scientists here and government there and leadership there, we actually are losing agency. That to be who we are and realize our potentials, we need to say we're the architects of our own destiny. And how do we start taking those steps to be the architects of our own destiny? That if we wait, we'll wait a long time, because begging bowls are always there, and we can't beg and beg and beg. We have to change, and we can do that. We have multiple examples where we take charge, and we take charge in a supportive environment. Yes. We can achieve great heights.
Yes, I think one thing that I'm really taking away from this is that women's vulnerability is a function of our social and economic sort of situation in African society, and that everybody, has a role to play in terms of, in order to reduce the vulnerability of women by empowering women and I guess empowering boys as well, that they too have the power to protect the women, the girls around them, the women in their lives through education, but empowering women with opportunities that allows them to be able to make certain decisions for themselves. We are actually coming to the end of our podcast, Prof. Can I just, perhaps you could leave us with your final thoughts on the high impact actions that you would like to see, the thing that you say, if we were to get one thing right, it has to be this, because that would be very impactful and would be very transformative. What would that be?
So, I'd say something that I've said throughout this conversation. Young women 15 to 24 years are centrally important for social cohesion and our ability to rise as a continent. And if we don't invest enough at a point where they are vulnerable, where they mental cognitive ability is still maturing, and that we start to lose them for multiple reasons, then I don't think we're going to reach our potential. And so that is the good starting point. But it's how do we enable, empower, and nurture young women that enables us as a society to rise. And that includes investments in young men early enough so that they understand what their responsibilities are, and what is it to be a man without having toxic masculinities. And that requires all of us to play a role. I think the writing is on the wall. We know what we need to do. Let's do it. Let's do it together, and let's really enable Africa to rise. It is its moment to shine. Let's shine.
Professor Abdool Karim, it's a pleasure to have you on, and thank you so much for sharing your insights with us.
Pleasure. Bye.
And to our audience, thank you for listening. Please subscribe or like us, or simply send us your comments, or including what topics you'd like to hear on Let's Talk About Health in Africa.